Okay, I think I'm going to get started. Before I introduce our speaker, Dr. Tu, I just wanted to thank everyone for coming and also let you know that we've decided to elevate everyone to panelists so we can sort of see each other or at least chat in the Q&A section. So um, thanks. So in case you're wondering, doing a little bit different this week to see how it goes. It's great to see you all. I'm Courtney Lyles. I'm the director of our Center for Healthcare Policy and Research, and my colleagues, Dr. Jeff Hotch and Dr. Bill Daler, are joining me here to facilitate our weekly seminar series. This week, we are really fortunate to have Dr. Lina Tieu present to us. Dr. Tieu is a postdoctoral scholar in CHPR, and her research centers on the implementation of interventions to improve access to and quality of health services with a focus on safety net healthcare settings. And she has a specific interest in what she'll talk with us today about is related to behavioral health, mental health, and substance use. Prior to joining CHPR, Dr. Tieu completed her PhD in health policy and management at UCLA. And she also was an employee in the UCLA Center for Health Policy Research, our sister center at the UCLA campus. And one of her projects for her dissertation research is going to be, I believe, the topic of her remarks today. So thank you so much for joining us, Lina, and take it away.
Thank you, Dr. Lyles. I really appreciate the introduction. I'm really grateful for the opportunity to be here today to talk to you about a few studies I engaged in as part of my dissertation work while I was at UCLA, looking at the multi-level factors and their relationship to the receipt of treatment for unhealthy alcohol use. And in discussing these studies today, in addition to highlighting some findings from the studies, I also want to discuss some of the challenges we faced when conducting the research and how we navigated those. So first, I want to acknowledge the team of researchers and collaborators who have contributed their expertise and time to this work, including the members of my dissertation committee, colleagues from the UCLA Center for Health Policy Research, and Dr. Lyles for her support as I continued to work on the dissemination of these studies during my postdoctoral training. I also want to acknowledge the sources of financial support that have allowed me to conduct this work, as well as parts of this presentation were prepared using a limited access data set obtained from NIAAA, as well as from data from an evaluation supported by funding from the California Department of Healthcare Services. And the findings and conclusions of this presentation do not represent the views or opinions of these funders and agencies. So why the focus on alcohol use? We know that unhealthy levels of alcohol use are linked to numerous adverse health conditions and outcomes. There is increasing evidence that alcohol use may have a dose-response relationship to some of these outcomes, including cardiovascular disease. And from 2020 to 2021, it was estimated that there were 178,000 alcohol attributable deaths in the US, which represents a 29% increase from 2016 to 2017. And this reflects evidence that the COVID pandemic really had a negative impact on rates of unhealthy alcohol consumption, as well as its associated outcomes, such as several studies finding an increase in alcohol-related liver disease during the pandemic, even among younger patients. It's also been estimated that around 1 in 10 adults reported indicators of past year alcohol use disorder, which represents alcohol use that has resulted in significant problems or consequences. And despite this burden, we know that treatment for unhealthy alcohol use is severely underutilized. It's been estimated that less than 1 in 5 adults with alcohol use disorder ever receive treatment, with rates being even lower when looking at past year receipt of treatment. Evidence also suggests that treatment for alcohol use is often initiated when individuals present to healthcare settings for alcohol-related medical problems or advanced consequences versus addressing problems earlier in the continuum of alcohol use. Given the underutilization of treatment for alcohol use, the goal of the studies I'll describe today was to examine factors at multiple levels, influencing whether or not individuals engaging in unhealthy alcohol use receive treatment. And as the overarching conceptual framework for these studies, I used the multi-level health outcomes framework, or MHOF, developed by Dr. Rashan Bastani and colleagues at UCLA. This framework provides a multi-level socio-ecological model that considers both immutable and immutable factors, as well as supports at the individual, provider, and health system settings that influence the implementation of health interventions and ultimately affect health outcomes within the broader context of the political and economic environment. So here the focus was to examine factors at various levels, as well as supports and barriers that ultimately affect whether or not people engaging in unhealthy alcohol use receive treatment. And given the growing evidence of alcohol's effects, even at lower levels of drinking, and pushes to promote earlier identification and treatment of alcohol use, I also wanted to examine these factors among a broader population of patients, including those in the general population exceeding US guidelines for alcohol use, as well as primary care patients receiving care from safety net hospital settings. So to provide some context on terminology referenced in this presentation, for the studies I'll talk about today, I referenced the definition of unhealthy alcohol use as that which increases the risk of negative health and life consequences based on guidelines from different agencies about the level of alcohol use that may result in increased risks of adverse outcomes. And then the US guidelines for alcohol use are based on a number of standard drinks, which you can see here varies based on the kind of alcohol being consumed. But basically a standard drink is that which constitutes 0.6 fluid ounces, or for those of us who prefer metric system, 14 grams of pure ethanol. There's also variation in the definitions and classifications of alcohol use patterns from different agencies. And here I show some guidelines from NIAAA and SAMHSA outlining specific patterns of drinking from lower to higher severity that may lead to alcohol-associated problems. So at the time of the study, NIAAA's guidance outlines risky drinking as consuming 8 or more drinks per week, or 4 or more drinks in a day for women, and 15 or more drinks weekly, or 5 or more in a day for men. And at a higher severity, binge drinking constitutes consuming a large amount of alcohol within a short period of time, while heavy alcohol use has been defined by SAMHSA as binge drinking on more than 5 days per month. So as you can see, these guidelines note different levels of risky alcohol use for women and men, and also differ based on the time interval one is consuming drinks. So they're a bit complicated and can also differ by agency. I also reference alcohol use disorder, which is a condition defined within the DSM-5 as experiencing at least 2 of 11 problems as a result of one's alcohol use. And some of these problems include neglecting your life roles, spending additional time drinking, experiencing social or interpersonal problems, and experiencing physical and psychological consequences. As an aside, it's an interesting time right now as there is currently an independent panel of scientists reviewing evidence on the risks of alcohol to inform the development of updated guidelines that will be issued by HHS and the US Department of Agriculture in 2025. So there's an opportunity to update these guidelines to be more inclusive, as well as to reflect the most recent science on the risks of alcohol use, as well as changes experienced during the pandemic. For the first study I'll discuss today, the focus was on assessing the relationship between individual level factors and the receipt of help for unhealthy alcohol use. While a lot of work has been done to better understand how individual level factors influence receipt of treatment, many of these studies have focused on those with higher severity alcohol use patterns, including those with alcohol use disorder, or those presenting to healthcare settings with problems related to alcohol use. So here, I was interested in assessing how individual level factors influence treatment receipt among those along a broader continuum of unhealthy alcohol use, including those who are regularly exceeding guidelines, all the way up to these higher severity patterns of drinking, such as binge drinking and heavy alcohol use. And so the goal here was to identify those within this broader group who may benefit from targeted interventions to promote the receipt of treatment. The data for the study came from the National Epidemiologic Study Survey on Alcohol and Related Conditions, the most recent or third wave of that. And this is a survey administered by the National Institute on Alcohol Abuse and Alcoholism, or NIAAA. And while it was last administered in 2012 and 2013, this survey remains one of the most comprehensive sources of population-based data on alcohol consumption and experiences in the US, as well as use of other substances, medical conditions, and behavioral health conditions. So it's a very rich source of data. The survey is also administered in multiple languages, including English, Spanish, Chinese, Korean, and Vietnamese, and also oversampled among racial and ethnic minoritized groups, as well as younger individuals. And it also includes an assessment of substance use disorders using criteria from the DSM-5. The NISARC-3 also employs complex sampling methods, which allows for the application of weights to produce naturally representative estimates. So for this study, the goal was to look at receipt of help among those who regularly exceeded US guidelines for alcohol use along this broader continuum to find this exceeding guidelines on at least a monthly basis within the prior year. So limiting the survey sample to adults regularly exceeding US guidelines, there were 6,467 individuals in the sample who either exceeded guidelines for alcohol use, engaged in binge drinking, or engaged in heavy drinking on at least a monthly basis. To assess the characteristics of individuals who regularly engaged in unhealthy alcohol use and how these characteristics differed between different drinking patterns, I used weighted, descriptive, and bivariate analyses. And to assess the relationship between individual level factors with receipt of help for unhealthy alcohol use, I used a multivariable logistic regression with the outcome of receipt of help of any type of help for alcohol use within the prior year. And all of these analyses were weighted to be generalizable to the 2012 US population using sample weights provided by NISARC. We also defined receipt of help from a wide range of sources and combined these into one outcome with evidence that help from support groups and other sources outside of the healthcare system also having effectiveness, and then also for some populations being more accessible sources of help. So looking at the overall sample, we found that 17% of the general population, or 40 million US adults, regularly engaged in unhealthy alcohol use. Among this sample, 76% regularly exceeded these guidelines without meeting these higher criteria for these higher severity patterns, binge drinking or heavy drinking. Just over half of this sample also met criteria for alcohol use disorder, with the prevalence increasing from 48% among those exceeding guidelines to 80% among those who were regularly engaging in heavy alcohol use. And these results highlight the high burden of consequences of unhealthy alcohol use, even among those who did not report engaging in these higher severity alcohol use patterns. In addition, there's a high proportion of individuals who regularly exceed alcohol guidelines who do not meet IUD criteria and whose alcohol use may be more likely to be overlooked in healthcare or social service settings, and have also traditionally been left out of studies examining unhealthy alcohol use and its relationship to treatment. Looking at specific individual level factors, we found that the majority of US adults regularly engaging in unhealthy alcohol use were male, under age 65, non-Hispanic, white, had at least a high school educational attainment, had lower income, and also had private health insurance. And looking at these factors stratified by alcohol use patterns, some trends emerged showing increasing proportions of those with lower socioeconomic status as the severity of alcohol use increased, including an increasing proportion of individuals with less than a high school educational attainment, with household incomes of less than $20,000, with Medicaid or lack of any health insurance as the severity of alcohol use pattern increased. Examining the outcome of receipt of help for alcohol use in the prior year, despite regularly engaging in unhealthy alcohol use, we estimate that only 5% of US adults received help within the past year. And given that half of the sample met criteria for alcohol use disorder, and 1/4 regularly engaged in higher severity patterns of alcohol use, this indicates a significant underutilization of treatment or help to address alcohol use. Consistent with previous studies among those with higher severity alcohol use, we found that there were racial and ethnic disparities in receipt of care, with those reporting being non-Hispanic, Black, or African American, or Asian, Native Hawaiian, or Pacific Islander being significantly less likely than white non-Hispanic individuals to receive help. On the other hand, factors associated with greater likelihood of help for alcohol use included being age 35 to 64, having higher educational attainment, having Medicaid but not private insurance. Um, all of these factors were associated with greater likelihood, and then consistent with what is known about treatment often being sought once more severe consequences have resulted. Those reporting liver disease, having had acute care utilization, as well as an increasing number of alcohol-related problems, was associated with greater likelihood of receiving help for alcohol use. Some of the challenges we faced in doing this work included limitations in the availability of comprehensive data sources on alcohol use, with many surveys asking about specific patterns of alcohol use, or lacking data on receipt of treatment that could be linked to this. And from a health services viewpoint, we know that there are also limitations in screening for alcohol use in healthcare settings, as well as variability in how data on alcohol use is captured in healthcare settings, which also presents challenges for assessing alcohol use using electronic health record data in many systems. I think there are also hesitations about whether self-reported data on alcohol consumption represents an accurate measure of how much people are drinking, given social desirability bias, as well as difficulty in assessing one's alcohol consumption, given the varying guidelines and definitions of standard drinks, as well as the variability in how frequently people may drink. We also dealt with a lack of a direct measure of receipt of help or treatment linked to this alcohol use data, and thus had to rely on a self-reported measure. As I discussed earlier, there was also not great consensus on definitions and thresholds for unhealthy alcohol use. So as I mentioned, it'll be interesting to see how these guidelines are updated in the coming year, as well as low prevalence of receipt of help for alcohol use across different sources that we found in our data. This resulted in us using a combined measure versus assessing who may seek help from different types of sources of treatment for alcohol use. For the second study that I'll talk about today, the focus was shifted to assessing the relationship between efforts at the health system level that may influence whether or not people receive treatment for alcohol use. Specifically, as part of the prior Medi-Cal 2020 waiver, California's public hospitals participated in a value-based program called PRIME to promote improvements in ambulatory care. And within this program, many of California's public hospitals were incentivized to build their capacity to address behavioral health conditions by integrating behavioral health infrastructure and processes within their primary care settings. So given this investment by hospitals in improving their ability to address behavioral health conditions among their primary care populations, I was interested in assessing whether the level at which hospitals implemented behavioral health integration was associated with receipt of care related to alcohol, including the receipt of appropriate care as well as acute care utilization, serving as a proxy for health outcomes. And while this analysis focused on behavioral health integration at the hospital level, we also controlled for patient level factors that I've listed here in bold. The study used data from Medicaid fee-for-service and managed care claims from 17 designated public hospitals in California, including all 12 county operated and 5 University of California hospitals. And this data was obtained from a larger evaluation of a public hospital redesign and incentives in Medicaid program, which was led by Dr. Nader Porat at UCLA. For the study, we focused on primary care patients with a documented diagnosis related to alcohol. And from the population of patients eligible for PRIME, which includes Medicaid managed care patients and patients with at least 2 primary care encounters within a year, the sample was narrowed down to 6,196 patients with an alcohol-related diagnosis. Given our interest in assessing the relationship between hospital-level PHI and receipt of alcohol-related care among patients, I applied multi-level logistic regression models controlling for these patient-level covariates. Here's the timeline of data collection. So as you can see, the program, PRIME program started in 2016. Around the midpoint of the program, there was a survey administered to key informants at each hospital that assessed measures of behavioral health integration, which provided the measures of BHI level that we used for this analysis. And then following that, we identified an index period where we identified these patients with at least one alcohol-related diagnosis and excluded those with diagnoses in the prior 3 months to try to identify a sample of patients with a new episode of alcohol use. And then in the year following that, we examined the claims data to assess its healthcare utilization related to alcohol use, as well as these acute care outcomes. In order to assess the level at which hospitals had implemented behavioral health integration, as I mentioned, I used measures from a prior study in which we had applied survey measures to assess hospitals in 10 different themes relating to infrastructure and processes for behavioral health integration. And based on their responses, hospitals received scores from 1 to 6 in each theme, which were combined to create composite measures in the domains of infrastructure and processes related to behavioral health integration, as well as an overall measure of behavioral health integration from 1 to 6. And given the complexity of this measure of behavioral health integration and all of the things that are involved in implementing this within the systems, we took an exploratory approach to exploring the relationship between hospital-level behavioral health integration and receipt of treatment for alcohol use among these patients. In addition to exploring whether this global measure of behavioral health integration was associated with treatment, we also explored whether specific subcomponents of BHI listed here may be related to receipt of care. Looking at the sample of patients with an indexed alcohol-related diagnosis, over 2/3 were male or had a racial and ethnic minority background. Almost 1/3 had a non-alcohol liver disease diagnosis or a non-alcohol substance use diagnosis, and 1 in 5 preferred a language other than English. While 1/3 of patients had an alcohol-related primary care visit in the year following their index diagnosis, fewer had encounters related to detoxification or other procedures, and only a minority had claims related to timely initiation, which means intervention within a 14-day period after their diagnosis, or engagement, which relates to intervention within 30 days after this initiation event. And for these, we used specifications based on HEDIS measures. Acute care utilization was high, however, with almost half having an alcohol-related ED visit and almost 2/3 having an all-cause ED visit. And looking at the relationships between BHI level and these outcomes, we found that this composite measure of overall behavioral health integration was not associated with any these outcomes related to receipt of appropriate care. However, it was associated with a higher likelihood of all-cause hospitalization. And then looking at each domain of behavioral health integration infrastructure and processes, we found that higher BHI level in the infrastructure domain was associated with greater odds of receipt of alcohol-related detoxification, as well as all-cause hospitalization. For here, there's potential that hospitals with greater infrastructure for behavioral health integration may also have greater infrastructure for detoxification, as well as greater capacity for inpatient care. However, we did not find that scores in the behavioral health integration process domain were associated with any of the outcomes. This figure shows the examination of the relationship between the specific behavioral health integration themes and the outcomes of interest in our exploratory analysis. And here we see that all statistically significant relationships between these themes and outcomes were positive, and that the themes related to provider infrastructure, such as provider buy-in, as well as the proximity of primary care and behavioral health providers, and processes such as team-based care and communication were related to various outcomes related to receipt of appropriate care. Overall, we highlight some potential relationships between subcomponents of behavioral health integration and increased likelihood of receipt of appropriate care, but also higher likelihood of some of these acute care measures. Some of the challenges we faced in carrying out this study include that our measures of behavioral health integration utilized a pretty comprehensive survey administered to key informants at each hospital. And we know that leadership and staff at these hospitals are extremely busy, so that limited the ability to collect repeat measures, as well as to survey a wider sample of individuals at each hospital that are involved in implementing behavioral health integration in order to balance this burden of data collection for them. Behavioral health integration is also a multi-component intervention, as we've seen, very involved, and here was just one project within a larger value-based program, which adds complexity to our assessment of the relationship between behavioral health integration and alcohol-related care. And this informed our exploratory approach to this analysis. And then, as with any study using claims data, the data is subject to variability in documentation and billing, which affected the decisions we made about which outcomes we examined and the way we measured them. For example, relying on those which could be characterized by diagnosis codes, which were more commonly used than procedure codes for specific processes, such as screening for alcohol use. We were also limited to examining this relationship among hospitals that participated in a value-based program, which limited our cluster size and also did not allow us to have a measure of behavioral health integration among hospitals that did not participate in the program to act as a comparison. However, despite all of the hospitals, included in this sample, participating in the same program to incentivize behavioral health integration, we did see variability in the level of behavioral health integration that had been implemented among the hospitals. So in this third study, I focus on screening, brief intervention, and referral to treatment. And within the PRIME program, many hospitals were also incentivized to implement SBIRT among their primary care populations. And the hospitals reported their rates of SBIRT over the course of 5 years and also received incentives for meeting specific goals in this metric. SBIRT is an evidence-based approach to identifying and initiating treatment for substance use in primary care and other settings. And it consists of 3 steps. Here, screening, often universally among your patient population or primary care population, to identify those who may be at risk for substance use. And then among those screening positive, administering a brief intervention can include things like motivational interviewing or counseling to increase awareness of one's substance use, as well as to promote behavioral change. And then among patients who may require specialty care or more intensive treatment, referral to treatment, to specialty care, whether it's within your care settings or external providers of care. And although there's some conflicting research about the effectiveness of SBIRT for different populations and various outcomes related to substance use, there is evidence that SBIRT can reduce alcohol consumption and drug use. And as a result, the U.S. Preventive Services Task Force recommends screening and behavioral health counseling for alcohol and drug use among adults in primary care settings with a level B recommendation. But here in this third study, the focus was on assessing how hospitals implemented SBIRT while participating in this value-based program. And here the focus was on provider and health system level factors that influenced implementation quality, as well as outcomes within a sample of 22 hospitals that participated in PRIME, including 17 designated public hospitals included in the prior study, as well as 5 district and municipal public hospitals, which are generally smaller hospitals and often set in less densely populated areas. For this study, we analyzed biannual narrative reports from key informants in these hospitals. And these were reports, and progress reports that were required by these hospitals to complete as part of their participation in PRIME. The objectives of this study were to examine the trajectories of SBIRT implementation, specifically the status of standardized SBIRT processes at the end of each implementation year over a 5-year program, over the 5-year program, and then to assess the specific SBIRT strategies implemented and the challenges experienced by these hospitals. We applied template and content analysis methods to assess how SBIRT was implemented within the hospitals during this program. Here we see the trajectories of SBIRT implementation among the designated public hospitals, as well as these district and municipal public hospitals. And with the status at the end of each year representing intentional and standardized implementation of SBIRT processes in a sequential manner. So looking at the legend here on the bottom right, our goal was to assess at the end of each year which step of SBIRT the hospitals had implemented in a standard way, as well as whether these steps had been standardized among their full primary care population or a more limited population, as we learned that hospitals often started with a smaller population before expanding hospital-wide. And among the DPHs, we see that it took a couple of years for them to standardize screening for substance use. We also saw that most of the progress was made in the 4th year of the program. And by the end of the program, all but one DPH had implemented standardized substance use screening in their full primary care population. 3 had standardized brief intervention, and 8 had standardized processes for each of the 3 steps of SBIRT. Among the DPHs or DMPHs, we saw that standardization of processes also required a couple of years in the beginning of the program, but overall occurred more rapidly, with 4 of 5 of these hospitals having standardized all steps of SBIRT in their full primary care population by the end of PRIME, and with 2 having done so by the end of their 2nd year. Overall, across these hospitals, I think these trajectories show incredible progress made by hospitals in implementing SBIRT within a relatively short period of time. And then looking at the specific strategies implemented by hospitals for SBIRT, there was wide variation in the types of screening tools and strategies implemented by hospitals. Methods of screening centered on the use of EHR integrated templates, but also included the use of patient portals, patient-facing mobile platforms used at the point of care, as well as paper surveys. Staff responsible for screening varied from primary care providers, medical assistants, nurses, as well as front desk staff. Discussion of brief intervention in the narrative reports was less comprehensive than that for screening, but included discussion of provider conversations, formal training for providers and clinical staff to conduct motivational interviewing, as well as the dissemination of educational materials to patients about substance use. Staff conducting brief intervention included both primary care clinicians and staff, as well as specialized behavioral health providers integrated within the primary care settings. However, hospitals did not discuss details of their processes for brief intervention, including their specific structure for brief interventions, the number of sessions patients had, as well as specific criteria for conducting brief intervention versus referral to treatment. And then in regards to referral to treatment, hospitals frequently described it as occurring via warm handoffs for hospitals that had been successful at integrating behavioral health providers into their primary care spaces or had internal substance use specialists, while others relied on electronic referral systems, care coordinators, as well as electronic decision support tools, often linked to their screening tools. Internal and external treatment options included hotlines, integrated behavioral health staff, inpatient settings, as well as external providers, either formally or informally partnered with the hospitals. And then finally, hospitals used a variety of care coordination processes for substance use, including registries for patients with substance use conditions, Medicaid management, and collaboration with partners on treatment plans. And then following the framework of the expert recommendations for implementing change, or ERIC framework, we were interested in seeing the strategies that hospital used in implementing SBIRT in key areas of implementation. So for planning SBIRT, many hospitals discussed piloting their workflows within specific patient populations or among a subset of providers or clinics. For example, piloting among their English speaking patients first. Challenges to SBIRT planning included the additional burden on clinician and staff workloads, discomfort with discussing substance use, as well as a lack of treatment capacity to meet the demands of additional screening, which was sometimes discussed as a deterrent to wanting to expand their screening processes. In financing SBIRT, meeting the metrics for the value-based program was a priority, but some hospitals also noted seeking additional external funding, and a couple also implemented internal financial incentives, including incentives for those staff who completed SBIRT training. Strategies for managing quality included various tools, including dashboards and reports, which required regular auditing of SBIRT rates, as well as providing feedback to providers and staff through emails and meetings. Education of personnel involved education of personnel who were involved in delivering SBIRT required extensive efforts through a wide variety of strategies and venues. And SBIRT also required a great deal of restructuring through the hiring and engagement of behavioral health clinicians and staff, as well as expanding the capacity of primary care providers to address substance use through the use of SBIRT processes and in delivering medication-assisted treatment. Prominent challenges included integrating SBIRT within the electronic health record, as well as existing clinical workflows, as well as difficulty in expanding treatment capacity due to behavioral health and medical staff shortages and turnover. Challenges we faced in this study included, again, the burden of collecting organizational data from a busy group of practitioners. For this reason, we utilized these progress reports that were completed by leaders of the hospitals involved in the program, which allowed us to have a regular source of narrative data on their activities related to SBIRT. However, there was variation in the depth as well as the focus of reporting between the hospitals. Again, SBIRT was just one of many metrics that hospitals were incentivized to improve as part of this value-based program, which required us to comb through data on what the hospitals were implementing within the wider program and to make decisions about what was most relevant to their implementation of SBIRT. And finally, the period of analysis did cover the period of the onset of the COVID pandemic, which affected hospital processes, as well as the depth of data collection during this time. So collectively, these studies serve to provide some additional context on the multi-level factors that may influence the receipt of treatment for unhealthy alcohol use. First, these studies highlight individual level factors that may be important in addressing underutilization of care, including racial and ethnic disparities in the receipt of care, and other factors related to treatment, such as insurance coverage and access among a broad continuum of unhealthy alcohol use. Evidence on the burden of unhealthy alcohol use in the US population promotes a shift in the focus of alcohol interventions and research to include that which occurs earlier in the continuum, and ultimately to promote identification and treatment before individuals experience more serious consequences of alcohol use. And in particular, this focus is important among patients receiving care in safety net settings who may experience a high burden of health and social needs and thus be at greater risk for negative outcomes associated with alcohol use. The challenges noted in the comprehensiveness on alcohol use support improvements in the way alcohol use experiences and treatment are measured, as well as potential methods for measuring the quality and intensity of interventions to address alcohol use. And finally, by highlighting potential relationships between behavioral health integration and various alcohol-related outcomes, as well as identifying strategies and challenges in implementing SBIRT, there's a need for ongoing support of health systems in implementing and sustaining these evidence-based practices to address unhealthy alcohol use and use of other substances in health settings, particularly within settings with limited resources to support and sustain this intensive work. There's also a lot more to be explored in how to address the low rates of treatment for alcohol use, including a need for updated prevalence estimates on the burden of unhealthy alcohol use, particularly that which includes populations that may benefit most from early intervention. There's also a need to further explore implementation quality and outcomes associated with implementing evidence-based practices in other healthcare settings, as well as the sustainability of these interventions outside the context of a dedicated program. And given the underutilization and disparities observed in the receipt of treatment for alcohol use, there is a need for further research on the design and implementation of interventions and programs to address these gaps. And finally, there's potential to assess the longer-term impact of evidence-based practices to address alcohol use, particularly to assess the impact of these interventions on improvements in health outcomes, such as liver disease, cancer, and behavioral health outcomes. And given the investment in value-based programs and other initiatives to promote the use of evidence-based practices, there is also cause to assess how such practices impact healthcare utilization, affect rates of unnecessary care, and ultimately healthcare costs. So I appreciate the opportunity to talk to you all today about this work, and I welcome any questions or comments you may have at this time. And feel free to connect with me after today should you have any other questions or comments.
Thank you very much, Dr. Tieu. Really appreciate it. We are opening now the floor for questions. I believe, Dr. Tieu, there was a question submitted by Glorietta in the chat. Glorietta, would you feel comfortable going off mute and sharing your question with Dr. Tieu?
Sure. The question occurred earlier in your presentation where you had shown a couple of slides that showed the quantity of drinks, type of drinks, and then frequency of drinks. And then it was broken down by gender as to what would be like classified as unhealthy. And I was wondering, has that been extended? And I think you might have answered this further along in your presentation. Has that been extended to race and ethnicity yet? Because when I'm thinking, and this is outside of my wheelhouse, but I remember in one of our biology classes, a discussion on an enzyme deficiency, and I believe it was the Asian population, to break down alcohol so that the threshold of what level of consumption would need to be classified as drunk was lower when compared to like the Caucasian population. So when we're trying to like build this definition of what's considered unhealthy, I'm thinking maybe that might change by race and ethnicity.
Yeah, that's a great question. I personally am not aware of specific guidance based on one's race and ethnicity issued by different agencies for levels of alcohol use that may be deemed risky. However, the guidelines I show here are among the general population. And so I think these guidelines for one's personal use may really depend on your personal risk factors for alcohol use, including chronic conditions, any behavioral health conditions you may have, obviously pregnancy, and other individual risk factors that one may have that really may affect how you are influenced by alcohol and its effects. And so I think that's something that will be interesting to see in these upcoming guidelines on how that is addressed. But I think what I've seen with some guidelines is that even if there's a general cutoff that we see here for what is deemed to be high risk drinking, it's also tempered by guidance that a lower level of drinking in general is better for your health. I'm not sure if that answers your question.
It does. Thank you.
Great, thank you.
Super. So we're in the middle of question and answers for Dr. Tu. If you'd like to type something into the chat or the Q&A, please go ahead. If you want to turn on your camera and actually raise your hand, you can do that. Or if you want to, you can do the virtual raising of the hand that looks a little bit like that. Dr. Tu, you mentioned you worked on Medicaid data. Can you talk a little bit about that? Many of us may not have had that pleasure, either trying to obtain it or seeing how clean it is once it has been obtained. Can you tell us just a little bit about what it was like to work with Medicaid data?
Yes. I was fortunate to work with an evaluation team on this evaluation of a waiver as part of the last Medicaid waiver. And so thus we had access to claims data among these patients and so the purpose of the value-based program was to improve care with a focus on Medicaid patients. So a lot of the work to clean the data and to generate various variables related to these care outcomes had been done as part of the larger evaluation. So I was fortunate to come in and be able to identify the specific research question and carve out this analysis as part of that project. One of my interests, as Dr. Lawless mentioned, is really identifying and evaluating interventions that can improve care for patients receiving care from safety net healthcare settings. And so I felt really fortunate to be able to have access to this data from Medicaid patients across a large sample of hospitals in California.
Nice, thank you. I'm looking for questions, and in the meantime, I'm wondering if you had, this is challenging and mean, but that's just how I roll. If you had to say bottom line it, like one sentence or less, what do you think your results mean?
Yeah,
Isn't
I
that mean?
think, yeah. Yeah, but an important question for sure. I think, I mean, I err on the side of caution that there is a lot of evidence of the consequences of alcohol use, even at lower levels of consumption. We also know that treatment is severely underutilized. And so it's important to examine interventions, policies, and practices that can really address these gaps, address disparities in care. However, these relationships are complex and require, I think, further attention on which of these interventions work, as well as how they can be implemented in a manner that work, since the same um, practices and policies may not work in every setting. And so I think, I know that might be longer than a sentence.
No, it's pretty good. What I think I hear you saying, maybe more research is needed.
Yes, more research as well as more support, and more, yeah, in-depth research into the implementation of these policies and practices to really support systems in doing this work in a feasible but also effective manner.
Nice, nice. So we've got a little bit more time. If you've got a question for Dr. Tu, I'm going to continue asking unwanted questions. This was not randomized, was it?
No, no. So, yeah, this, as I mentioned, the two latter studies were part of a value-based program. And so, all of the public hospitals in California participated in this program. And while not all of them participated in every component, including the behavioral health components of it, they were not randomized to do this work.
So is there anything I need to worry about when I'm listening to your results, given that they come from data that weren't randomized, or I don't need to do any worrying?
Yes, definitely. I although some of the studies we tried to look at the data in a way that has staggered data collection to when we examine the outcomes. Since this was not a randomized trial, it can be subject to reverse causation or other associations, and so I think yeah, I think some caution is needed in interpreting these results, and these should be interpreted as associations rather than causation.
Nice, thank you. And Laura, I believe, has a question. Laura, are you able to unmute and ask your question, or would you like me to?
It looks like Laura is not able to unmute. Let me read the question.
Okay, so do you see your question in the chat, or should I read it, Dr. Tu?
I can read it. Yeah. So how I did all
Especially the
my
first
research
line, the first line of that question, please.
Yes. How did I decide on pursuing MPH and a PhD in public health versus other career paths in healthcare? Great. Yeah. So after my undergraduate program, I actually pivoted from molecular and cell biology. I began volunteering at a public health clinic in Berkeley, and was really impacted by my interactions with patients, many of whom really relied on the clinic for a lot of their care, and was inspired then to go into public health and pursue an MPH from there. And then specifically, my research interests have been informed by, uh, in part by like personal experiences. I've had I have known people who have experienced these issues with substance use and things like that have inspired my work. And then in general, I think I just have an interest in with these increasing pushes for interventions within primary care. Um, uh, being able to contribute to ways to implement these things in an equitable, feasible, and sustainable manner. And yeah, I'm happy to chat with you offline as well, if that's helpful.
That is wonderful. Thank you very much, Dr. Tu, for sharing your research with us as well as your journey. I hear you saying that you're open for people to contact you. Can you share your email just once again for people to follow up? There'll be people
Yeah.
who are watching this as well later on the recording. Perfect. You can see her email in the chat. Thank you very much, Dr. Tu, and hope everyone has a good rest of your day. Take care, everyone.
Thank you all. Take care.
Bye for now.